Yohann Renard will tell you something about the anatomy, which is the basis of all that we are doing. Yohann, please.
Thank you so much. Wow. Hello, everybody. Victor, Michel, thank you so much for the invitation. I'm very happy to be here. And we will begin a face-to-face with David Lurie about anatomy. So I will make some drawing for you. And we will begin with the groin anatomy. Can I start? So let's go for the groin anatomy. And we will first begin with an anterior view. And we will begin first with the superficial anatomy. Here is the bone with the acetabulum, the pubic tubercle, iliopubic arch. Here is the obturator foramen. And laterally, the hip joint with the femur, which is cut just here, medullary channel. The greater trochanter is here, the lesser trochanter is there. Here is the iliopectineal eminence and the inguinal ligament with the iliopectineal ligament just here forming two lacuna. Laterally is the muscular lacuna and here is the vascular lacuna. Laterally in the muscular lacuna is of course the psoas iliac muscle inserting in the lesser trochanter is the most important muscle of the body. And medially is the vascular lacuna with the femoral artery and the femoral vein coming from the external iliac vessels. And of course, in the middle here is the femoral channel. We will draw now the insertion of a muscle, is the pectineal muscle forming the pectineal ligament or ligament of Cooper. Is an adductor muscle, of course. And just in front of this muscle, we will find the lacunar ligament or ligament of Jean-Bernat. In the anterior part, superiorly, we will find the rectus muscle, the right rectus muscle, which is cut just here in the level of the umbilicus. And the distal insertion is, of course, on the pubis. Here is the tendon of this muscle on the pubis with lateral fibers, also called Henle ligament. And now we are drawing the superficial part of the lateral muscle, of course, the external oblique muscle, just here, with a large muscular part, but also a large aponeurotic part. This aponeurotic part is here, and it covers also the psoas iliac muscle, forming the fascia iliaca, and we will find here the femoral nerve. The aponeurotic part is forming some pillar. Is the lateral pillar of the superficial inguinal ring, forming the lateral edge of the superficial inguinal ring. Then the medial pillar, forming the medial edge of the superficial inguinal ring. And then other fibers and the pillar coming from the contralateral muscle, also called posterior pillar or pillar of Coles. The aponeurotic part of this muscle is forming, of course, the anterior rectus sheath, but also the linea alba, right here. The linea alba is followed by the fundiform ligament of the penis, just here. And we will cut this external oblique muscle in the level of the umbilicus, just here. So this muscle is cut. And we will draw the skin. It's always important for the student to draw the skin, to localize very good the area with the penis and the scrotum and the thigh right here. From the superficial inguinal ring, we will see the spermatic cord. It's made of several fascia, two fascia, a deep spermatic fascia coming from the transversus fascia, and the superficial spermatic fascia coming from the external oblique muscle. Between these two fascia, we'll see there is some fibers of muscle. We'll see that just after. Here are the intercrural fibers described by Nicaise, and of course the spermatic cord is reaching the testicle. Now we will draw the deep structures with the same anterior view, always the coxal bone, obturator foramen, and the inguinal ligament. We will cut this inguinal ligament just here to show its round shape. So also I call that also hammock shape, because there is just behind some transversalis fascia fibers forming the iliopubic tract of Thomson. It is the deep fascia of the transversus fascia. And then the rectus muscle with the Henle ligament. Once again, the vessels, femoral artery and femoral vein. Iliopubic ligament, Cooper ligament, lacunar ligament of Jean-Bernat just here. And we will draw again the external oblique muscle with the posterior pillar of Coles, and this external oblique muscle will be cut just here when it forms the anterior rectus sheath. And just behind, we will see the other muscles. And first, the internal oblique muscle with the large aponeurotic part just here, forming also the anterior rectus sheath and forming the conjunct tendon. This internal oblique muscle are a large aponeurotic part and laterally a large muscular part. This muscular part inserts in the inguinal ligament. So I say it inserts in the inguinal ligament. It's not very the reality, but it's better to say that to the student. And just behind the third muscle is the transversus abdominis muscle, forming the transition line here between the muscular part and the aponeurotic part. It is the semilunar line, of course. Here are the deep structures. And here, below the conjunct tendon, we will find some transversalis fascia with a ligament. Right there is the Hesselbach ligament or interfoveolar ligament. On this ligament, we will find the vessels, epigastric vessels, coming from the external iliac vessels and running in the posterior part of the rectus sheath. So medially of these vessels, we will find the medial hernias or direct hernias. Laterally from deep inguinal ring, it is the lateral hernias or indirect hernias, and inferiorly here, of course, the femoral hernias. The important thing for me is the nerves. We should know where the nerves run, and we will show that just in a minute. Here from the deep inguinal ring, we can find the spermatic cord with the deep spermatic fascia coming from the transversus fascia and the superficial spermatic fascia coming from the external oblique muscle. And between these two fascia, we will find the cremaster muscle coming from the internal oblique muscle. Now the nerves, there are three nerves, of course. The first is the halio-hypogastric nerves, reaching the anterior rectus sheath just here, coming from L1. The second nerve is the ilioinguinal nerve, coming also from L1 with three distal branches, one femoral, one scrotal, and one pubic branches. Is the territory of this ilioinguinal nerve. And the third is the genitofemoral nerve with the genital branch and the femoral branch of the genitofemoral nerve. Once again, genitofemoral nerve, genital branch, and femoral branch. Here we can find the lateral cutaneous nerve coming from L2 and L3, and the femoral nerve. Once again, halio-hypogastric, ilioinguinal, genital branch of the genitofemoral nerve, femoral branch of the genitofemoral nerve, lateral cutaneous nerve, and the femoral nerve. After that, we will see the posterior view, the laparoscopic view of this area, the anterior and superior iliac spine, the posterior part of the rectus muscles. Between both, we will find the linea alba, is the tendon with the Henle ligament. Linea alba just in the middle, forming inferiorly the fundiform ligament of the linea alba. and the level of the umbilicus right here. The posterior edge of the inguinal ligament will be here, with the iliopectineal ligament, muscular lacuna, vascular lacuna. In the muscular lacuna, it is the pseudoiliac muscle, of course, which is surrounded by the fascia iliaca just here. Inside the fascia iliaca, the femoral nerve, coming from L2, L3, L4, lateral cutaneous nerve, L2, L3, and here the vascular lacuna. External iliac artery, external iliac vein. In the middle, we are defining here the femoral channel. The anterior and the posterior rectus sheets are drawn here. We can find the anterior and the posterior above the umbilicus, formed by the lateral muscle. Here is the aponeurotic part of the transversus abdominis muscle, forming the linea semilunaris. It is the transition line between the aponeurotic part and muscular part of this muscle. The fibers are transversal, horizontal, like this, forming also inferiorly the conjoint tendon with the internal oblique muscle. This muscle is cut just here, also inserting in the lateral part of the inguinal ligament. Laterally here is the internal oblique muscle, which is also cut right here. And then the superficial one is the external oblique muscle with a very large aponeurotic part in the inferior part of the abdomen, forming the inguinal ligament, of course, which is cut also here. On this drawing, the peritoneum is removed, but we will find the deep layer of the transversalis fascia. Deep layer of transversalis fascia is forming the inguinal ligament of Thompson, the deep inguinal ring with the deep spermatic fascia, and then the interfoveolar ligament of Hasselbalch just here. This interfoveolar ligament of Hasselbalch is forming the linea aquator of Douglas. It is the inferior edge of the posterior rectus sheath and is followed by the epigastric vessels, forming here the Hasselbalch triangle. We will find the spermatic vessel just here, coming from the aorta, and then the funicular artery, which is the second artery of the spermatic cord, and then the vas deferens. To explain the ends of this vas deferens, we have to draw the bladder with the urachus just here, and the ureter coming from the posterior part, just here. The end of the vas deferens is reaching the prostate with the seminal vesicles just here. And this vas deferens is followed by the third artery, the differential artery coming from the internal iliac artery. Here is the obturator foramen with the obturator vessels, and we can find some anastomosis between the obturator vessels and the epigastric or external iliac vessels. It is the corona mortis vessels running just here on the Cooper ligament with a high risk of bleeding during this section. Left side, we will draw the peritoneum, and we can find here the umbilical ligaments coming from the obturator umbilical arteries, and here is the peritoneum. We also draw the cirrhosis with the violet. Here is the peritoneum in violet. And when the peritoneum is lying on the structures, it will give some ligaments, and we will find 3 ligaments. One medial ligaments formed by, lift by the obliterated urachus. It is the medial umbilical ligament. Just here, the lateral umbilical ligament coming from the obliterated umbilical artery. external vessels are here, and the epigastric vessels are forming the lateral umbilical ligaments. Between all these ligaments, we can find some fossae. Here is the supravesical fossae, medial umbilical fossa, and lateral umbilical fossa with the external hernia, internal hernia, femoral hernias, just here in the fossae. And we will find, again, right side, the three locations of these three primary groin hernias. Of course, the nerves, genitofemoral nerve with the femoral branches, genital branches just here, the lateral cutaneous nerve, femoral, genitofemoral nerve, of course. We will define again the triangle. It is the doom triangle, triangle of doom, with the risk on the vessels, triangle of pain, and the risk on the nerves when we don't preserve the transversalis fascia. We will conclude this drawing with two sagittal sections. One first sagittal section through the artery and one second through the Cooper ligament. The first sagittal section through the artery, we will draw now the iliopubic branch and the artery, external iliac artery forming the femoral artery, and the conjoint tendon with the transversus abdominis muscle, internal oblique muscle, external oblique aponeurosis, forming here the inguinal ligaments, transversalis fascia, forming the deep spermatic fascia, the ligament of Thomson, the fascia of the thigh, and the peritoneum. Here is the beginning of the spermatic cord with the cloacac ligament, spermatic vessels, vas deferens, and funicular artery just here. And the second drawing will be performed through the Cooper ligament. So we will find the insertion of the pectineal muscle, is the Cooper ligament or pectineal ligament, and the pectineal muscle right there. Conjoint tendon, transversalis abdominis muscle, internal oblique muscle, external oblique muscle, inguinal ligament, transversalis fascia, ligament of ligament of Thomson, the fascia of the thigh, the deep spermatic fascia is here with the vas deferens, cloacac ligament, artery, and the pampiniform vein. Now, the peritoneum and this location will be very important. This is the Bogros space. We will find again the femoral artery, lateral artery, median artery is the lateral artery just here, indirect, direct, femoral. And this Bogros space is very important. The preperitoneal space, perhaps there are two layers of the transversalis fascia. We will speak about that today. And now the location of the mesh. During the Liechtenstein, the mesh is here, superficial, and this mesh will be, of course, put in the three nerves with the high risk of pain when very bad performed. And during laparoscopic repair, the mesh is here on the Bogros space, and of course, the risk on the nerves is not the same. During Liechtenstein, the risks are on the ilioinguinal, iliohypogastric, and genitofemoral nerve. The last repair is the tip repair, where the mesh is deep on the Bogros space, but using an open approach. So once again, about the nerves. During Liechtenstein, the risks are on the iliohypogastric, ilioinguinal, and genital branch of the genitofemoral nerve. But during deep repair on the Bogros space, during TEP and TAP, the risks are on the lateral cutaneous nerve, femoral nerve, and the two branches of the genitofemoral nerve, as I can draw here. And of course, it's really important to know the sensitive territories of these nerves in case of chronic pain. And the location of the femoral branch of the genitofemoral nerve is here in the middle of the thigh. The sensitive territory of the lateral cutaneous nerve is here, laterally from thigh. The genital branch of the genitofemoral nerve is on the scrotum, as well as the ilioinguinal nerve, just here is the same, and the femoral branch of the ilioinguinal nerve is here in the middle of the thigh. The femoral territory is here, the saphen nerve, and the obturator territory is here. And I think using this drawing, it is easy to understand this risk on the nerves and the anatomy of the groin and I just marked the territory, sensitive territory of all these nerves. And of course, I thank you for your attention.